Good afternoon. Welcome everyone. Please make yourself comfortable, and we are about to start. We are starting with the opening session of Ketamine-Assisted therapy, and we'll start with our organizers and hosts, Ksenia Vosnetko, the head of Lisova Polyana, Alice Wilson, Executive Director, Heal Ukraine Trauma, and Oleg Orlov, the head of UPRA, Ukrainian Psychedelic Association. Of course, it's all very traditional, unique experience. We live in the time and we're getting a unique experience. We wish we never had this experience. But I would like to remind you all who does everything possible for us to be able to gather here. And we are working for them. And so thank you very much for joining this difficult work. And we have many people, the titans, who we will never hear, who we will never talk to, we will never hug. And these are the people that we are still standing and we are still fighting the horde of the Russian Federation. Let's have the moment of silence. Let's remember everyone, every man and woman who did everything possible for us to be here. Thank you, everyone. And as introduction, I would like to remind you all that this center is the place which is working with invisible wounds. And the necessity of this work is more and more relevant with every day. I always say that when the war is over, physical injury will heal, and people will need only rehabilitation and support, but psychological traumas, they will grow exponentially. And we never stop improving our work, we never stop doing it better and better. We are learning new methods, we are adding them to our work. And even today I was supposed to have a business trip, but I didn't go because today we got 6 people who were former prisoners of war. Some of them had been in Russian prisons for 7 years, some 2 years after terrible conditions, after torture. And those who are standing against new methods of research or new methods of treatment, these are the people who never talk to people who have trauma caused by war. Our team, we have this experience, and we talk dozens and hundreds of people every day. We are ready to fight for every new method which will help us heal this trauma faster. We are ready to fight for every new method, and whether it's popular or not, maybe it's not completely evidence-based, but we are ready to work on new methods. And today, with the team, starting in summer this year, with Renaissance Fund, we started Ketamine-Assisted therapy. And it was not easy to start in a state-owned institution. It's still not easy. We constantly receive lots of unpleasant information about what we do and why we do it, and that it's unnecessary. But we don't listen to those people. We keep going. And so it happens that ketamine is the winner among all other allowed psychedelic substances, so at least we have ketamine, and we need to work with it more actively, research it more, prove its efficacy and effectiveness, and to prove people wrong if they're against it. And so today's conference is very useful for all of us, for those who organize it, for those who visit it. And I'm very happy that it's happening. I'm glad that we are moving forward, even with lots of negative feedback and obstacles. And in our institution and in the Ministry of Healthcare in Ukraine, you are always going to have support and reliable shoulder partners. So welcome to our wonderful Hogwarts, and have a productive day. And I wish the best of luck with your work in the future.
Вітаю. Я Еліс Вілсон, виконавчий директор
I'm
Heal
Elise
Ukraine Trauma.
Wilson, Executive
We're so
Director of
glad
Heal
that you all
Ukraine
chose to
Trauma.
spend your Saturday here with us
Ми
at
дуже
the
раді,
Ketamine
що ви
Symposium.
обрали в
Today,
цю
you'll get
суботу
to hear
бути
from
з
some
нами на
incredible
нашому
practitioners in the
симпозіумі. І
field,
сьогодні ви
learn
почуєте
about current
багато
ketamine
цікавої
projects in Ukraine,
інформації
and
від
network with
наших
your colleagues.
спеціалістів і спеціалісток.
Heal
І
Ukraine
почуєте
Trauma
про
is
те, що
honored to support this
відбувається в
event, and we
мережі
hope that it serves as
людей,
a
які
starting point
працюють
for
із
further
цим
collaboration in this field.
питанням. І
At
Heal
Heal
Ukraine
Ukraine
Trauma
Trauma,
намагається
our mission
підтримувати
is
ці
to help
зусилля.
Ukrainians
І
heal from
ми
the trauma of
намагаємося
war.
допомогти
We have two
українцям
focus
зцілитися
populations,
від
veterans
травми
and
війни.
children.
Ми
With
працюємо
veterans,
із
we're focused on helping
ветеранами і
introduce
з дітьми.
psychedelic-assisted
З
therapy,
ветеранами
and
ми
with
працюємо
children, we're
над
focused on
психоделічною
implementing
терапією.
programs that help them
І
process the traumatic
щодо
stress
дітей
to
ми
prevent longer-term
допомагаємо
mental health conditions from
їм
manifesting.
подолати стрес,
So
того, щоб
I'll be sharing more about our
попередити
work after the coffee break,
довготермінові
but for now, I'd like to
наслідки.
extend a
І я
heartfelt
після
thanks
кава-паузи
to
буду
everyone
більше
who made
говорити
today possible.
сьогодні.
Our
І
co-host,
хочу
Lisova,
подякувати зараз
our
нашим
partner organization, UPRA, our events team, our
співорганізаторам, це
speakers,
і
and everyone
UPRA,
else who
і
made
Центру
today possible,
психічного
and to all
здоров'я,
of you
нашим
for being here
спікерам і
today. I
спікеркам,
know some
і
of you
усім
traveled from quite
вам.
far to
Я
be
знаю,
here, and
що
we
багато
really
з вас
appreciate it.
приїхали здалека,
I'll
щоб
turn
бути
it
з
over
нами.
to
Ми
Oleg Orlov,
дуже це
and
цінуємо.
let
І
him speak.
зараз Олегу Орлову передаю слово. Слава Україні!
Доброго дня, всім чутно мікрофон.
Can you hear me?
Я би теж хотів почати з
Good.
подяк.
So I would like to start with the words of thanks. So we already thanked those who protect our front line and who ensure like air defense for Kyiv, and we can be here thanks to them. So I will talk about gratitude, and I will talk about some news that we have. So I would like to thank people for what they are doing, and I will talk a little bit about UPRA, our organization, this is Ukrainian Psychedelic Research Association. So that is an NGO, and first of all we do advocacy. And now, as it was mentioned, we can work only with ketamine among all the methods that could be available within this area. So we work with advocacy, research, and we hope that we will expand our practical work as well. And we say that we are a space for people to meet. So we are not a professional association, though we have doctors, researchers, and people from academia. Also, we have some veterans, some people from IT sector, designers, and we bring together all these people with the joint interest. And I think that we as Ukrainians can be strong when we work together, and we are able to achieve great results. So hopefully with psychedelic-assisted therapy, it will only happen like that, because we are lagging behind if we compare ourselves with colleagues from abroad, but we hope to become a scientific and a practical center. Well, that's not a good reason why we have to do that,
Сьогодні вже
but we
майже,
do
скоро
have this
майже рік, як
chance.
пройшов з
And soon
засідання
there
Комітету
will
Верховної
be a
Ради
year
з
since there was a
питань здоров'я нації,
parliament
спеціально з цієї тематики.
hearing on
Рік вже десь
the
приблизно
health
йдуть обговорення,
of the nation, and
тимчасової спеціальної
where they
комісії у справах
discussed
ветеранів,
relevant
там різних
questions, and there is
підкомітетів.
the special
І
commission on the rights of
наразі
veterans and
МОЗ в
all
тому
kinds
числі
of
працює над
committees,
порядком
and
проведення
also the
досліджень,
Ministry of
які
Health, they
сподіваємося,
work
що
on
до
the
кінця року
procedures for research
не
studies.
доведеться,
So
вдасться все-таки
we hope
прийняти.
that by the end of the year we will be
Подяка
able
співпраці з
to have
нашим
relevant
органом державної
documents
влади, з
approved.
комітету,
And
зокрема,
I would
і
like to
Дмитру Гуріну,
thank
який цю
Dmitro
тему
Gurin,
курує.
the MP
Хотілося б
who
подякувати
helps us
міжнародним нашим
promote
партнерам,
this
Тілу Trauma,
topic. And I would
за
like
те,
to
що,
also thank our international
створили
partners,
організацію
Heal
22
Ukraine
року, і за
Trauma,
те, що
for
допомагаєте не
creating
просто,
the organization and supporting people not
конкретними
only
речами,
with funding,
вводити і
but also
розвивати
with very specific things, with
конференція в тому
developing
числі,
the
про
areas
метод фонду
which are
відродження.
very
Дякую.
helpful. Also, we would like
Цього
to
року
thank
наша діяльність такою є
the
більше
IRAP
цілеспрямованою завдяки підтримці. І на
Renaissance
наступний рік
Foundation,
ми також
and
робимо, вже почали
for
проекти з
the
стандартизації
next year we
методу
plan a
психодично-асистованої
project
терапії загалом.
on
Хочемо зробити таку
standardization
кваліфікаційну рамку, по якій можна
psychedelic-assisted
потім буде робити різні
therapy,
освітні
so
програми.
that we have a
Тому
framework
вас
within
запрошуємо
which we can have
долучатися до
different
обговорення цієї
training
рамки, розвивати
programs.
метод також
So
разом
please
з
join
нами,
our efforts
навчатися разом з нами. Думаю,
in
бажаю
our
плідної всім конференції.
training and educational efforts, and let us have a good conference. Thank you.
Добре, дякую дуже за відкриття нашої конференції. Ми можемо переходити до першої частини
After the
такої
opening
більш
remarks,
наукової,
we can
скажімо так, де ми
start
будемо
our
наші
first
доповідачі
part,
поважно
more
розкажуть про
scientific part,
дію
where
кетаміну,
our
про його
distinguished
роботу
speakers will talk
в
about
кетаміноасистованій
how
психотерапії.
ketamine works
наших
and
учасників я
about
дуже дякую.
ketamine-assisted
Не буду вас,
therapy.
я тут
And I would like to
залишуся одна
thank
вже
all
тоді,
our
так?
panelists.
Бо я
So
знаю, що
now
ви
I can
дуже
let you
зайняті.
go. I know that
Пані
you're all
Ксенія,
busy
дякую вам
people.
дуже.
Thank you all so much.
Так як у нас буде наступне відео,
And we
я
will
трошечки
have
відійду
a
від центру.
video now. So I will sit here.
Значить, наступна доповідь,
So now
наша головна
we will
доповідь, на
have
жаль,
a
фізична
key
людина, котра буде доповідати,
presentation,
не
and
присутня.
unfortunately our speaker was
Це
not be
дуже
able to
відомий
come and join us.
Девід Нат,
This is
професор,
Dr. and Professor
англійський
David Nutt
психофармаколог,
from
який спеціалізується на дослідженні
UK,
препаратів, що
and
впливають на
he
мозок. І
specializes
різноманітних
in
станів, включно
research
змінені стани свідомості.
in different states of
В
consciousness
нього
and different
надзвичайно цікава
medications.
біографія, і в
He
нього
has a
дуже
very interesting
цікаві
biography
книжки.
and
Те, що
very
я маю
fascinating
сказати,
books that he published.
ну,
And
такої, як
I have to say
ми зустрілися з ним в
that
Варшаві
we met in Warsaw
цього літа. Там відбувалася
this
цікава
summer.
конференція також.
There was also
присвячена
an interesting
психоделічно-асистованій
conference
терапії.
there on
І
psychedelic-assisted
мені пощастило просто
therapy.
сидіти поряд з ним
And I was
під
just
час
lucky to sit
обіду.
next to them when we
І,
had
звичайно,
our
була можливість
lunch.
обговорити
And of
багато
course, we used
питань
this
з наукової
opportunity
сфери,
to discuss
розвитку
many
психоделічно-асистованої
scientific
терапії, його бажання
questions,
допомогти в Україну. Але, якщо
psychedelic-assisted
чесно, ми говорили
therapy,
зовсім
and
не про
his
це.
desire to
Всі 2
help
години, а ми,
Ukraine.
здається,
But to
останні
be
залишили
honest,
той
we
ресторан. Він
discussed a
питав
different
про
thing.
Україну,
So for
про
2 hours, he
про
was
військових,
asking me
про цивільних, про
about
те,
Ukraine,
як це
about
бути
the
по
war,
центру
about military and
цієї
civilians,
ситуації, як витримувати
and
це.
how
І
people
це
cope
людина,
with
котра
this
не просто
situation.
видатний
So this
вчений,
is
це
a
людина,
person who
котра
is not just a
дійсно
distinguished
вважає,
scientist.
що
This is a
що ми
man
робимо щось
who
надзвичайне.
really
Україна
thinks
робить щось
that
надзвичайне, українці
Ukraine
роблять щось
is
надзвичайне.
doing
І він все, що він може
something
зробити, він хоче допомогти.
unimaginable, something great,
Тому
and
він
he would like
одразу
to support
відгукнувся,
our
коли я
efforts.
звернулася до нього. Ми
So,
звернулися до нього
when we asked
щодо участі в цій
him to
конференції.
take part in
І
this conference,
підготував коротку
he
доповідь
said that he
запису,
would be
але
happy to do
пізніше
that,
о
and he
2:30
prepared
сьогодні
a session for us,
він
and
просто зараз
at
знаходиться в Вашингтоні, в Сполучених
2:30, a
Штатах,
bit
там з
later, he will
також бере участь в
join us
якихось наукових
because he's now
конференціях.
in
Але він
Washington taking
зранку, у
part
нього
in
це
some
буде дуже
other
рано,
activities.
приєднається на питання-відповіді. Тому кому
It
буде
will be
цікаво
morning for him
поставити йому
and he
питання,
will join us
дочекайтеся
for a
другої
Q&A
30. Всі
session. So
наші
if you are
доповідачі
interested,
будуть на
please
сесії
prepare
питань-відповідь.
your
І
questions
що
and at
хотілося також
2:30 we will
сказати,
have a
що він
Q&A
також
session.
був, ну, я йому пояснила, що, на жаль, його книжки ще не
explained the
перекладені
professor
українською
that
мовою,
unfortunately his
і
books
він
have not
всіляко
yet
буде
been
сприяти. Ми зараз
translated into
маємо певні
Ukrainian,
розмови з
and now we
видавництвами.
are
І
talking to
сподіваюся, скоро
publishing
ви
houses,
побачите його
so
книжку
hopefully
«Психоделіки»
soon you
українською
will
мовою.
see
Ми
his
принаймні зробимо
book
для цього
called
все можливе.
Psychedelics in
Тож
Ukrainian.
прошу,
We will do everything possible for
лекцію.
that. So please let us start the lecture.
Hello, it's a pleasure to be able to talk to you today about the utility of ketamine for mental health treatments. I'm sorry I can't be with you, but I will be answering questions later today. So why use ketamine? Well, it has a long-established safety record for anesthesia. It's a very safe drug because it does not suppress respiration, so it can be used outside of hospitals. It's short-acting. Its effects last only 1 to 2 hours, and there's a rapid return to normal consciousness. Ketamine disrupts negative thought loops and enhances neuroplasticity, so allowing people to lay down new, more beneficial ways of thinking. It has proven efficacy in the treatment of depression, and there is growing evidence in pain syndromes and in PTSD. Ketamine, like psychedelics such as psilocybin, and also other drugs such as scopolamine, all work on glutamate synapses in the brain. In essence, what they do is produce an increased release of glutamate, and that then leads to a depolarization, an increase in firing of the neurons which connect the different parts of the brain. That changes brain function in a fundamental way, and it allows the brain to recover from deeply entrenched processes which occur in disorders like trauma. How do we do psychedelic therapy? In essence, it's a 5-part process. The first part is to make sure the patients are eligible, that they're not on medicines that would interfere with the treatment or potentially make the treatment more harmful, and that they do not have diagnoses which could make the treatment problematic. Once they have crossed the criteria threshold for treatment, then they come to the clinic. Generally, the day before, they're prepared. They're told about what's going to happen during a ketamine trip, how we will deal with the issues that come up, and any measures we might want to take, for instance, of blood pressure and heart rate. The next day, the same therapists who educated them, prepared them, are present during the trip, and here's an example of how we do it. We generally have quite a pleasant room, a quiet room, a relaxing room that can minimize anxiety and allow them to get the best out of the experience. And then the next day, they have an integration session where they talk about the experience and try to use it to help them overcome, for instance, depression or PTSD. And these post-treatment sessions can then carry on for as long as people find them beneficial. Now, typically with ketamine therapy, we do 4 of these sessions a week apart. It's important to get the set and setting correct. Relaxation before ketamine therapy can be practiced so that people are able to maximize the experience. And they're encouraged to go with the experience, not to try to resist it or control it. And also before the sessions, we help them set an intention. What are they trying to get out of these sessions? And here's a lovely comment from one of the patients in one of our ketamine treatments. Safe setting is important. The therapists need to be competent and reassuring. And here are some quotes from patients who were very reassured by having the confidence in the therapists and in the medication. And of course now we do have a lot of evidence of the utility of ketamine plus psychotherapy for a variety of different disorders, including trauma disorders. This is a schematic which helps people understand the mechanism of action. In essence, we believe that people with chronic depression or trauma disorders, in their brain has become very disorganized into peaks and troughs. Depression itself, of course, is a word which means a deep trough, and that people cannot escape from those thoughts, the negative thoughts in depression, the trauma memories in PTSD. And we know that these peaks and troughs are driven by the changes in the way the brain can switch its many processes. During the trip, the energy landscape of the brain becomes much more flattened. There are fewer mountains, there are fewer depressions. And that flattening of the landscape explains the trip. It explains the experiences of the trip. And it explains why people can escape from memories, traumatic memories during the trip. But we do not scan people during the trip because that would impair the therapeutic benefit. We scan them afterwards, and afterwards we see that the brain maintains a level of reduced extremes. The brain is flatter, the energy landscape is flatter, and that allows people to escape when they start having those repetitive thoughts of depression or trauma again. And this we can see, we can measure using imaging studies. And this is one kind of imaging we have done, which compares the impact on the brain of ketamine, of psilocybin and LSD here, compared with many other drugs, sedatives, anesthetics, alcohol, etc. A blue image means less power. The brain is less stuck in a particular frequency, and these are frequency domains of the electrical activity of the brain waves. Psychedelics reduce the persistent, repetitive behavior you see in the brain, whereas sedatives and anesthetics increase it. And it's this breaking down of routine, repetitive frequencies, oscillations, that allows people to escape from the memories and the thoughts which are so disturbing to them. And one of the things we've known now for 15 years is that ketamine, along with other psychedelics, suppress activity in this brain region. And this brain region is the region called the medial prefrontal cortex. And this brain region drives negative, repetitive, self-destructive ruminations in disorders like depression and PTSD. By breaking down that activity in this brain region, people can escape from those thoughts and begin to think much more differently about the future, not reflecting on the past, but looking to the future. And like other psychedelics, ketamine also increases neuroplasticity. Neuroplasticity is a process where the brain grows more synapses and more of the things called dendrites that the synapses are on. And that means there's more connections in the brain, there are new connections in the brain. And so the new ways of thinking that people achieve as part of ketamine therapy can be laid down because the brain is in a better state to learn these new approaches. And we can even image, and this is actually in rat brain, we're doing the same in human brain now, we can image increases in these synapses using this particular tracer. And here are just a couple of quotes from patients who had ketamine therapy. One of the really important aspects of all psychedelic therapy is increased connectedness. People are more connected with themselves and with other people. They're connected with the world, with nature. And that increased connectedness is enormously beneficial to their mental state. It allows them to focus away from the trauma to more positive ways of living. And it puts them back into the world, which they've been excluded from as a result of their trauma. So you can read these accounts and really understand the individual experiences, which are so critical to recovery. And then finally, I want to bust a few myths about ketamine. There are people who think it's dangerous. The reality is it's extremely safe. It is widely used across the world as an anesthetic. It's on the WHO Essential Medicines list. It's the major anesthetic used in sub-Saharan Africa because it does not need an anesthetist. It is that safe. It was originally developed as a buddy drug in Vietnam so that soldiers could administer it to their buddies who were been blown up or had limbs damaged, etc. The second myth is that it can be addictive. Yes, people do abuse ketamine when they use it recreationally. But in our experience, in hundreds of people given ketamine therapy for disorders like PTSD, given 4 treatments, we find that people don't become addicted. In fact, they seem to escape from other addictions because, as well as breaking down trauma memories, ketamine can break down addiction memories. So it does have a wide utility in many different psychiatric disorders. And I believe it is a revolution in psychiatric treatment. And because it's a current legal medicine, it's able to be used in countries such as Ukraine where you don't have access to psychedelics like psilocybin. So I hope you find this talk helpful, and I will be coming back later today to take questions. Thank you very much.
I hope that it was interesting. And now we are going to listen more of medical and scientific part of ketamine, but from the perspective of Ukrainian scientist. Vyacheslav, could you please join us? And while Vyacheslav is coming up, I will start talking about him. Vyacheslav has PhD in psychology, he's an addictologist, and he works with veterans in Lisova, Polyana, so he is our host. And in his presentation, we will talk about the combination of psychedelic assisted therapy with therapy. Good morning. Therapy. Good morning. I always like starting from far away from a history of China, and today I will start with miracle. All people are always looking for a miracle of healing. It was the Holy Grail, or what else people were looking for? Some like the Sorcerer's Stone. Now it can be some urine therapy or like something like that. But ketamine is not a miracle in the same way as either psychedelics. All psychedelics, including ketamine, it's not only about the substance itself, but we also need to work before using it and after. And that's what I want to focus on. I want to talk about this neurophysiological basis of therapy. Okay, so I need to figure out the clicker. So you can see this is a small illustration about miracle. I like working with beautiful pictures. Everybody is looking for some magic herbs that will solve all your problems. but magic substance that can solve all your problems, or as Barmele in the Soviet movie said, that I will drink this castor oil and I will never be sick again. But let's move forward. I'm not going into chemical aspect of ketamine. David Nutt told us enough about this. I don't need to repeat again and again everything that you already know. So this is the chemical structure, and this you can see the substance, but here I will need to talk a bit more. I want to see the molecule of ketamine, which looks so pretty here, and it's so nice to see this molecule of ketamine. This image was created by Mr. Stahl. I really like his books on pharmaceutical therapy. So ketamine has direct impact and on all these receptors listed on the slide, and then indirect through glutamate on AMPA receptors and CORS receptors. And this indirect impact, that's what is interesting for us if we talk about antidepressive effect. Let's move forward. And once again, I'm not going into details of all these cascades of how ketamine acts, but what I would like to mention, this is MDMA receptors, and because as they are blocked, so the activity of glutamate increases, and there is activation of neurotrophic factor, and so we about BDNF, and then mTOR. And this cascade of reactions leads to increase of neuroplasticity, so the genesis of synapses and these neural growth, and that's already the base for quick antidepressive effect, which starts almost immediately right after using the substance, and then it's a base for long-term psychotherapeutic effect. So the long-term antidepressive action, if we use this possibility, if we use this window of resilience, then when we have this improved neuroplasticity, which substance gives us, and then we continue with psychotherapy. So this is really short. This really short explanation how the receptors work through the action of glutamate on the receptors. So then we have there, so MDMA and mTOR, they increase, and that's how it works. And again, so you can see all these receptors, they increase these factors. And once again, this is another picture of Mr. Stahl, and he explains how these little mushrooms grow on synapses. So there was a small one, then glutamate came, and then mTOR activated, and we have other these points of contact in synapses. And as a result and of modification of synapses or the improving neuroplasticity, we see the improvement of adaptive neuroplasticity. Any psychedelic, not just ketamine, using the modulation of neurotransmission, so they increase neuroplasticity. And then we can see different types of neuroplasticity. So we already discussed this time. So we discussed the generation of new synapses and new connections. Then we have structural neuroplasticity. That's when the changes are happening not on the level of synapses, but on their new ways and it's as if like the rivers during the flood, it creates new ways, and so that's how the new connections of neurons are created. I see your surprised faces, but I was even more surprised when I was reading some research, scientific research, when they say that neurons can migrate. And the last type of neuroplasticity, this is behavioral, and this one has the highest value. As we increase two previous plasticities, we see the improvement of behavioral plasticity. We can teach new skills and increase in their adaptive possibilities. So this substance, when it acts, it gives us the possibility to open this window of resilience, and then we can use more effectively psychotherapeutical methods, and it prolongs what substance does in like multiple times. I will show you some results of research, and you will see this is not just I am talking out of nowhere, but it is actually evidence-based. You already seen this picture in the previous presentation. I saw it at Mr. Haracek lecture. For that reason, I decided to keep the name. And here we can see in this picture that basically we can see these little mushrooms that we saw on Mr. Stahl's picture. So this is how it looks. And let's move forward. And here something interesting starts. So the reason why I had been talking all this time. So the cognitive behavioral therapy can improve and prolong the effect of ketamine. What does it mean? Ketamine without therapy, so then so in 4 weeks their effect recedes after 6 infusion. So 55 to 89%. But if we combine ketamine with the therapy, then it is 12 weeks.
So just mathematically, we see that it is 3 times as effective. So we have better remission, better efficacy. And those are pessimistic statements, actually, because I did not include the things that Mr. Garachik was sharing, because those studies are still ongoing. But what he said was actually quite more important. He was talking not about several weeks, but he was talking about 1 year. That is the period of time that he shared. Well, I will not be commenting on that, because Mr. Garachik is still continuing this research study. It is not published yet, but I think when it is published, I will share the results for sure. And there are 2 more articles I wanted to show. There are many of them, but those are ones I liked. There are these articles by Samuel Wilkinson, and it demonstrates very well these effects of ketamine in together with CBT for treatment-resistant depression. And we see how it was used. So there was screening first, then there were 4 sessions of ketamine therapy, and then psychotherapy was also happening. So you see 4 CBT sessions here in the scheme. And then week 2, this is where ketamine use is over, and then there is only CBT weekly for weeks 3 to 10. So what do we see? We see the efficiency, and here we can compare ketamine and CBT or no CBT, but that's not the most interesting picture. That is an interesting picture where we can see the green line and the blue line. So those were data for using either CBD or ketamine, and the yellow line shows the combined use of ketamine with CBT. And you can see weeks here. So week 12, it is 40 to 60%, so about half of people were still in remission. And if we look at week 16, here we have 40% of depression-free survival, and then the study was just stopped, so we do not know what happened at week 18 or at week 20. And that is what I wanted to show you. So there are no miracles which just happen. Miracles can happen if we work for it. This is what we need to do, using the medications and not thinking that ketamine is like a bottle of beer that you just drink and then stay happy forever. And that is like just short description of what we discussed. And here I was talking about using ketamine with CBT, and Mr. Garachik is also looking at it. I have talked a little bit, made kind of an announcement about the study he is doing. So, miracles can happen. Thank you for your attention. Thank you, Vyacheslav. I am sure that there are a lot of questions about this interesting presentation, but we will have a Q&A session later on. We'll have questions to all our speakers, so please write down if you have any questions. And if you feel that you would like to get more scientific information and you would like to know more about international studies, so there is a YouTube channel of UPRA, and there is a lecture of 2.5 hours by Vyacheslav, so you can check this video, and there he is talking about different research studies. So if you are interested, that is my recommendation. And now we will have the last theoretical presentation on the potential risks and benefits of ketamine. And Zach and Nika, please come on stage. I will tell a little bit more about you. So we have Zach Skiles, a doctor of psychology, and he is a consulting psychologist at Heal Ukraine Trauma and a trainer at the group program of Ketamine-Assisted program. So actually, Nika and Zach, they are both our trainers in our program, and Zach used to work in the Portland, the US, in the laboratory, supporting the research on using MDMA for PTSD use, and also he worked with methamphetamine studies. Zach is a veteran, and he used to be a Marine, and that is an important part of his work in Heroic Hearts project. He works veteran using ayahuasca, psilocybin, different methods. So when our training is happening, our participants sometimes ask about those methods, just theoretically in Ukraine, of course, but for which issues, for which diagnoses, different approaches and different substances can be used. Also, he teaches in Berkeley at the California Institute. And now we have Nika Levy. She's a registered nurse and she got a bachelor's degree in nursing from Pittsburgh University, and now she is a DNP student at Johns Hopkins University. And Nika is almost a Ukrainian. She is a daughter of Jewish Ukrainian immigrants, but you can see that she is actually almost Ukrainian. So please help her practice her Ukrainian language. And she's our trainer, she's our facilitator in our program. And there will be another presentation in our second part of our symposium. She works with veterans as a nurse in the emergency unit, and also works in research on psychedelics, and she is an activist in policy and advocacy, and so she is also took part in the program for using the psychedelic in working with trauma, and she works with the psychedelic-assisted therapy. So now over to
Вітаю. So we'll be presenting on the risks and benefits of ketamine today. So a little overview about where ketamine research is currently at. So if you didn't get enough neuroscience, here's some more. So these are all the parts of the brain in which ketamine affects that we know of. And the reason I highlight this slide is because a lot of these regions and receptors and pathways we see in psychiatric disorders.
So the ketamine safety profile, what I like to highlight is phase 1 trials establishing safe and effective use when observing the risks and benefits of medicine, its dosage, and protocols that it will go through before establishing phase 2 or 3 trials. And so far, ketamine trials have determined that specific dosages with protocols in ketamine can be safe and effective. So what we're looking at in these next trials are kind of the evidence basis. So the spectrum of weak and strong evidence that folks are bringing forth, being weak evidence, small samples, a lack of reliability, lack of replication, limited generalizability. And then the other end of that spectrum being stronger, so it's larger sample sizes, reliable methods, proof of replication, generalized to multiple populations.
So every drug has its risks, and the adverse effects that we see common with ketamine include headache, nausea, dry mouth, somnolence, and some side effects that we see that we want to see when we use ketamine-assisted therapy include hallucinations, dissociation, depersonalization, but yeah.
So I like to look at the generalized messages we are getting in the media right now when it comes to ketamine, because there are a lot of different informations that we're taking in. And then it's important to note that about 40% of articles contain inaccurate information relating to ketamine. So when we talk about enduring benefits, safeties, or treatment protocols, 40% of the time that information is actually not true. Benefits discussed actually can be 3 times the amount that we're actually talking about safety. And a lot of the times when we're talking about safety, we're talking about the negative aspects. So we're getting kind of 70% of that conversation around fear-mongering at times. Well, there can also be a benefit to really discuss what you're stepping into. Is it actually safe? 40% of those discussions as well can be around addiction, specifically around the aspect of becoming addicted to ketamine. What I like to tell folks is that it's a case-by-case basis. Everybody has their own physiology. So providers need to address the patient's beliefs and expectations of media and their own kind of intentions.
So the current off-label uses for ketamine in the US include depression, which we also use in the Ukraine, suicidal ideations, treatment-resistant depression, PTSD, and last night when I checked at midnight, alcohol use disorder was added to that, so that's really exciting to see.
Novel areas of treatment that are just popping up here, so opioid use disorder, cannabis use disorder, cocaine use disorder, eating disorders, bipolar disorders 1 and 2, obsessive compulsive disorders, and autism spectrum disorders. So a lot of this is important to note as we're moving through phase 2 and 3 trials. These are the multiple populations that we're going to start looking into to make sure it's safe and effective.
So with major depressive disorder, studies are showing 50 to 100% effectiveness in remission rates following a single dose with the following day. Get this. After signs and symptoms of depression, rates were seen up to 29%. So what we're seeing with that is 50 to 100% rates of remission for depression within that day after dosing. And we're seeing these symptoms last up to 29% in the day after. And there's a rapid onset of antidepressant, anti-suicidal, anti-anhedonic actions. And the neuroscience under this is thought to be due to the EEF2 and the subgenual anterior cingulate cortex. So the studies suggest that these effects last 3 weeks to 3 months, and it is approved for MDD in the US and the EU. When it comes to suicidal ideations, ketamine has a profound and rapid effect for this disorder. One study noted that ketamine has the highest effects for SI, consistently ranging from moderate to large decrease in symptoms, lasting 3 to 7 days. So we're seeing that it's the most effective for this disorder. S-ketamine has already been approved in the US for acute suicidality, and there is strong evidence for ketamine showing safe and effective treatments, and it's already been used off-label in the US for its use for acute suicidality.
So PTSD, post-traumatic stress disorder. So one retrospective study found that participants who had survived car accidents who received ketamine 1 year after the traumatic event actually had an increase in PTSD symptoms. And something that I like to look at within the research when questioning kind of what's coming out is that perhaps in these sessions, folks were starting to look at their symptoms for the first time in a little while so that they were aware of their PTSD symptoms. There's also a possibility that folks are moving into a fear period neurologically, where when you're closer to an event, you have greater plasticity in the brain. However, a year out, there's a bit more concreteness to where those synapses have laid themselves. Further out from that year, you're going beyond the fear period, which might have a little bit more plasticity when jumping into a ketamine session with less of a fear reaction. Those are the type of questions that we're still needing to investigate right now when stepping into post-traumatic stress research around ketamine. So of the projected military veterans managing PTSD, 70% will manage depression symptoms. This subgroup consistently receives greater clinical outcomes from ketamine treatment. And we're looking at 80% of veterans reporting these symptoms, so 40% report a remission up to 3 months afterwards. These are considered strong evidence trials of larger samples to rest on. So bipolar disorder is one that I've managed quite a bit in many different veteran nonprofits. 2/3 of the studies that we've collected so far for the comparisons of clinical outcomes with unipolar depression and bipolar disorder have found little difference between the depressive symptoms or outcomes. It means they have about the same effectiveness. And so 1/3 reporting more significant improvements in bipolar disorder. The thought process is that they're perhaps more dramatic in the symptoms that are being reported, so you have greater effectiveness when it comes to treating bipolar 1, specifically for mania. So that mania has been seen in trials, however, sample sizes are not sufficient enough to determine what that aspect of care could be in the supports that we offer people with mania. It's less likely in these trials, they've reported that it's less likely to be experienced with intramuscular IM, transnasal or oral administration, but this is a case-by-case basis that I like to remind folks of. More evidence needs to be collected because we're looking at moderate states of evidence. Take it? All right.
Generalized anxiety disorder, GAD. So these studies are looking at all different types of general anxiety disorders, including social anxiety, and the underlying pathologies include disruptions within the serotonin pathways. So studies show that many different subtypes of anxiety disorders treated with ketamine evoke a 50% reduction of symptoms from a multi-dose protocol. There's good evidence, though there's more studies that need to be conducted looking at different sample sizes, different generalizability, and such. Obsessive compulsive disorder, so a little bit of neuroscience I'm just going to gloss over. So IV ketamine rapidly improves the symptoms of OCD. However, these effects are short-term. One study noted that when combined with therapy, the effects were prolonged. While the ketamine alleviated OCD symptoms, effects are not as significant as compared to treatment-resistant depression after the acute effects of ketamine subside. What this means is that what we're seeing with depression and treatment-resistant depression, the effects are much stronger and they last longer. There's conflicting data on the mechanism of action with ketamine on OCD. Participants are still receiving benefits as a result of ketamine-assisted therapy, but one study did note that there was an elevation in GABA levels as opposed to glutamate levels in the medial prefrontal cortex. So more studies need to be conducted here to really understand how ketamine is affecting people with obsessive-compulsive disorder. So this is scored at a poor level of evidence. The studies are heterogeneous. They have not been measured against current gold standard practices and guidelines. With eating disorders, chronic and complex anorexia nervosa has been studied, and ketamine has been found to have longer periods of remission versus standard therapy. Again, the effects for this disorder were not as significant as what we see with treatment-resistant depression. And there's poor evidence because it's only studied in this very small population, which is the chronic and complex anorexia nervosa, as opposed to bulimia and purging disorders as well. So hopefully more studies will be conducted here. Animal studies are promising, but scored at poor level of evidence at this time.
I believe, so I can take this one. So studies are showing a decrease in associated cravings and positive reinforcements for alcohol use disorder. So the suggested studies, when ketamine is paired with therapy specifically, that's important to note instead of just infusions, but when ketamine is paired with therapy, outcomes for abstinence are significantly higher than psychoeducation or benzodiazepine or therapy, or benzodiazepine with just psychoeducation. The abstinence as a result of ketamine with therapy, or CAP, has shown to last approximately 12 weeks after treatment for folks with alcohol use disorder. Psychoactive and mystical effects of ketamine for people who are prone to alcohol abuse lead to a significant reduction in its consumption, and the reduction there in reinforcing behaviors caused by drinking. So this is about fair evidence is what we're looking at for folks when it comes to alcohol use disorders.
Cocaine use disorder. So there's multiple studies that found that ketamine produces a positive effect after a single infusion as compared to the control, which was the benzodiazepine. Effects include decreased cravings, frequency, consumptions, and increased motivation to remain abstinent. One study did note that there was a higher effect with the group that was treated with ketamine and therapy. Again, that key component is that what Vyacheslav was saying earlier, therapy does prolong these effects. There's very preliminary data. It's only there's only a couple studies out there, I believe, on cocaine use disorder, so it's scored at poor evidence. As the research continues, we're hoping to see more promising evidence. Cannabis use disorder. So one study noted that with ketamine with a therapy, there was significant reduction in use, cravings, and non-reactivity to acute stress. And the study also found that participants significantly increased confidence in abstaining from cannabis in times of stress. The poor level of evidence at this time, there's not enough data to draw conclusions from this.
So opioid use disorder is one study connecting to low dose versus high dose for ketamine injections with opioid use. So it was noted that both arms reduce cravings and maintain abstinence with the first 2 years of follow-up. Unsurprisingly, higher doses of ketamine group that had the longer lasting effects, suggesting that the dose dependency is the response. Multiple doses of ketamine also resulted in higher rates a year out to that abstinence and lower rates of craving. So one study actually noted as well that ketamine was useful for the physiologic suppression of opioid withdrawal. Poor evidence was what we were looking at here too. More needs to be concluded. Polysubstance use. So one study for alcohol use disorder and for benzodiazepine use disorder together reduced a relapse in recent detoxified patients. So folks were not having as much cravings or relapsing into medications or self-medications. a study on combat veterans with PTSD and major depressive disorder and substance use disorder found significant impacts on PTSD and major depressive disorder, but insufficient effects on downward trends of substance use, which is something that there needs to be greater study around. So the limitations for study. Most of these studies involved adult males. Predominantly where substance abuse studies was alcohol use disorder as well as opioid use disorder. Ketamine was administered in IV rather than the other administration routes. Cognitive behavioral therapy was the dominant, as well as mindfulness-based stress relapse prevention, and psychological interventions during each experiential and integration session through the TIMBER, the trauma-related interventions using mindfulness-based extension and reconsolidation of memories. It's a mouthful. And ketamine-assisted psychotherapy. So the aspect of, again, pairing these ketamine infusion with therapy, having the greatest outcomes. Comparative studies with current practices are lacking, and the classic problem of placebo, where everybody knows that they have actually had the medication or not.
Promising data, so no daily requirements of ketamine are needed for the treatment of any of these disorders. Ketamine safety profile is well established, and the risk and most medication interactions are known. Adding therapy to ketamine treatments increases efficacy and prolongs benefits across the board. Studies are examining combinations of psychedelic-assisted therapy with conventional therapies, and there are studies expanding into autism spectrum disorder, eating disorder, OCD, and more. And while there is abuse potential for ketamine as a result of the sub-anesthetic doses producing the psychomimetic effects, studies are showing that in both depression and substance use, therapy may be mediated by the participant's perception of these psychoactive effects.
Takeaways. All right, so my takeaway that I like to leave everybody with is really that ketamine administration is a case-by-case basis. We've said it at the beginning and throughout. I want to say it again. It's a case-by-case basis with anybody who has their own individual physiology, to take it one step at a time with each individual. The psychedelic tool is in fact used in therapy and not a cure-all or magic pill. It's not a panacea. To ensure safety, ketamine-assisted therapy should be used according to approved protocols. Thanks so much, guys.
Thank you.
Окей. Ну, я сподіваюсь,
I hope you enjoyed the theory. I hope you got enough evidence and research. But still, remember all your questions, because
we will not have enough time for the most interesting practical sessions. But before we start talking about our projects, we have a distinguished guest in the area of psychedelic-assisted therapy. So I'm not mentioning that he is a politician, that he is a deputy, but this is a person who advocates for new methods of treatment for military, for civilians, for veterans. So Dmitro, could you please give us an update on the current situation? Hello everyone, I'm happy to see you all. I'm happy that we have so many people here. And I hope that next year we will have a 2-day symposium and we will have even more participants. And it is so far from the city, from Kiev, but you all came here. That is great. So I will talk about the regulatory framework for psychedelic-assisted therapy so that you can understand where we are moving to. So the first remark is that ketamine-assisted therapy is fully legal. And it is possible to do clinical trials and observational studies for depression, for different substance use disorders. So you can do that, and that is why this conference is so important. As for other things such as MDMA, psilocybin, and other drugs which are currently prohibited. At first, the ministry were quite progressive. They said that we will do observational studies using the model implemented in Israel and Canada. But at some point, they changed their point of view. They said that this topic is too difficult. We are talking about the first line and drugs here, and they said that we can only do clinical trials. And you know that MAPS in America, like 20 years ago, they chose this route with MDMA, but they were not able to reach any target, and they said that they will be doing some additional trials, and they will take like 3 years more. And if we are talking about clinical trials and MDMA, we can do that, but we would like to have independent money coming from universities, so that we won't have to do with patented molecules we can use actually molecules without any patents that we can later procure and use for our veterans. And it is hard to say how much time such clinical trials for MDMA could take. I think that for us it is easy to enroll patients now. We can enroll patients really fast, but the therapy itself, it takes 6 months. So in 1 year, if we run really fast, in 1 or 1.5 years, we can have a protocol to be approved by the Ministry of Health, and then there could be treatment and observational studies based on this treatment. And for LSD and psilocybin, the situation is more difficult. So people are scared of these substances. When someone hears about some new medical technologies, like on the surface, people say, okay, let's try, but when they have a look at side effects from psilocybin and from LSD, they understand that side effects are too severe and they don't want to work with them. But we continue the conversation with the Ministry of Health so that we could do studies for those substances as well. We want to open this whole list of first line drugs. Maybe not all of them are needed, but we should be open and we should have access to those options. And it's not about ketamine. So ketamine is already an approved medication, but it is important for us because it relates to psychedelic-assisted therapy. And if we are talking about clinical trials, then we are talking about 1 year, 1.5 years. Okay, so considering that Dmytro cannot stay with us for Q&A session, we decided to make an exception, and we can take 3 questions to Dmytro. So if you have good afternoon, my name is Anna. I have a question about MDMA. Could you tell in more details how the procedure for MDMA can look like? So you were mentioning some universities or some academia. So should there be some special department there working on developing this molecule, or what should happen? First of all, there should be the clinical base for the study. In universities, usually there are university clinics, so they can use those. Also, they can collaborate with some hospitals, and so this kind of study could be held in Lviv or in Kiev. In Kiev, there are some known problems with the quality of the medical department, let's put it that way. Lviv is safer for foreign researchers to come, so I think that Lviv Medical University, they could be the one to be implementers of the study, so that's my like favorite option for me. So have I responded to your question or not? MDMA is not a difficult molecule. That's not a problem. It's like with amphetamine. It's quite easy actually. We have a producer with licenses. They have a factory. They have all the chemicals and they meet all the requirements. They have all the licenses for medical drugs and for transportation, etc. So they are ready to work on that, and the cost would be $2 or $2.5 per gram. And we had another question. Wait, the lady over the participant over there was the first one. Sasha Statsenko, I have a question. So you are the person who sees psychedelic therapy in Ukraine in the future. What kind of recommendations would you give to a person who would like to work in the sphere in terms of certification, education, what the person should have to work in this area? And what kind of model would you choose? Oregon model or German model or Swiss model? So, I mean, for instance, if Lviv University implements this trial, we will have a situation that a psychiatrist will prescribe MDMA, and there will be specialists working with clients. So those specialists, what kind of training should they have? What kind of certification should they have? Okay, so we agreed with the ministry that we will have 3-level system. So one level is the psychiatrist prescribing the medication, the second level is the place where the service is provided, and the third level is the specialist working with the client. So the psychiatrist and the therapists working with the client, they need to get to go through training and get certificates recognized by the Ministry of Health, because the Ministry of Health also will be approving the training course. And during this education program, they will take the medication 3 times themselves, because they need to understand what is happening when the person takes this drug.
After that, this place which provides this therapy, it has to be medical establishment, so it cannot be veteran organization, for example. For now, it can be only in the medical establishment. And what do you need to do now? Now you can go and study, because it's always good to have some knowledge. And I think that you can already start working with ketamine-assisted therapy, because ketamine is a different substance, but the experience of working with patient with the changed state, then it is very important. And I think that you already can practice with ketamine-assisted therapy, because it's already allowed, and then you can go through the course for how to work with MDMA and join different trainings and courses. That's my advice. Or you can just follow the trainings that Heal Ukraine Trauma is organizing. And today we are going to talk to our not graduates. They're not graduates yet, so our first course participants. I have more clarification rather than a question. You said that MDMA is safer. No, I said about psilocybin and LSD, and in comparison with MDMA, so we like the side effects are not registered, like some serious side effects are not registered, at least from the experience working with veterans. So some and the person is happy when they take MDMA. It's of course it is important for a person not to take it more often than once every 3 months, but the person is happy, so we don't have some serious side effects. So that's why I mentioned that. So we agreed to answer 3 questions. Okay, we can allow one more. Yes, if people are really willing to ask, that's okay. Could you tell us, please, so why do we need to have clinical trials? Why can't we just promote substances to use in therapy? Like, why do we have to have our own clinical research to advocate then the substance to use in therapy? Because it's a drug and it's not registered as medication. If MDMA were registered in any country with strict regulations, so we were really hoping for the decision of FDA, because if it is registered if it is registered as medication, then we could have used a short procedure and we could recognize MDMA as a drug, like as medication, really fast. But if it is not registered in any country with strict regulations as medication, then we cannot do that, and everybody would be very tense. But if we work properly and if we follow the law, then a year and a half in these conditions of the war, then we can do the clinical trial and we can publish protocol and we can register MDMA as medication. Thank you very much. Thank you for all your questions. I hope that on our next event we will have some positive discussion around MDMA. And yes, next time we need to get together for a few days, not just one. Now I would like to give the floor, according to our agenda, I would like to give the floor to Vladislav Internetsky. And so he's psychotherapy, MD, the specialist in psychosomatic and the pioneer with psychedelic-assisted therapy, and he is the founder of the clinic Expio. In his presentation, Vladislav will share his experience when he started in 2018, and he will also talk about the ketamine-assisted therapy, working with veterans with resistant PTSD. Good morning, good afternoon, dear friends. You heard a lot about some scientific part, about chemical aspect, about physiology. For that reason, I'm not going to talk about it. I just would like to explain the road of CAT in Ukraine and where we are going. Somewhere in 2017, as any therapist or psychiatrist who work with difficult cases of treatment-resistant state, I was basically desperate that nothing worked, that antidepressants could work only for about 40% of patients. And even now in academia, there is a discussion what works, like whether placebo or actually the chemical formula of antidepressants, which is still an interesting topic to discuss. And I started to think that maybe we need to start xenon therapy, but it's pretty expensive, very expensive equipment. And as I had my scientific background, I tried to follow closely on all the new methods, what was going on in the world. And as one of my directions of psychotherapy, there's transpersonal therapy and psychology, which use this state of consciousness. And so I knew about psychedelic therapy. I had my own experience, and I was dreaming about this becoming possible in Ukraine. I also read about ketamine-assisted therapy because first research was published in 2010, and in 2017 there were enough papers which stated that it was pretty good and powerful method. And of course, I really wanted to use it and in my clinic. And then in 2017, at the same time, two miracles happened. Maybe not miracles, but two lucky chances. First, the Minister of Health at the time, Uliana Suprun, she allowed to use international medical protocols. And then there was the first protocol on ketamine-assisted therapy, and American Psychiatric Association, they published this protocol. And so I decided to try it out. I got the license to use psychotropic substances, and at that time there was still stigma, these are drugs, and of course now we have a lot more information and many people understand better that psychedelics, it's not a drug, but at that time it was complete darkness and fear around this topic. And as I had patients that needed that, I started with them. I remember my very first patient, how thoroughly we prepared, how we discussed it all so much. I was holding the syringe with diazepam, and then amintazine lying next to me. If there was some psychotic reaction, and everything was so unclear and so scary of what was going to happen. But it didn't happen. And I have to say, over the past 6 years, I never needed to use the syringes. And in those cases, when there is increased anxiety, even when it was agitation, there was still enough just to use psychotherapy. Breathing and methods like that that you use when people have panic attacks or like some severe anxiety. And so ketamine is a really safe substance to use. We started with a classic approach, infusion, then psychotherapy, then infusion again. But then, having read materials and having our own experience, like then we actually moved to ketamine-assisted therapy. So when we were doing therapy during the infusion, and this is the most powerful tool. And here Vyacheslav shared about this research and about infusion with CBT and then infusion. Yes, it can work, but from my perspective it is less effective than doing therapy during the experience. Of course, we cannot use CBT because there is no critical thinking, but then Jungian approach is the best because we work with metaphors and symbols, and that's what we need to work with in the process, with the information that shows trauma. And if at the beginning I followed very clearly the protocols which existed about measuring the dosages and only using it with depression, but then I followed different trials and research, and you already seen them, that they started to use it with PTSD, with different anxiety disorders. So this spectrum got expanded for us as well. And our colleagues, you've just heard that we have this research for different disorders and states, but officially, legally, still there are protocols, international protocols that we can rely on only around depression. So all other disorders or states we can work only as comorbidity. So when we have depression and in parallel one of the other morbidities that you already heard. We cannot work only with obsessive-compulsive disorder only, because it is outside the international protocol, which is approved by the Ministry of Healthcare. And today I can say that we have developed a lot of experience. We had more than 1,000 sessions with CAT, and in June I visited an international seminar in Barcelona where the leading specialists were invited from Germany, Spain, US. I listened to them and I understood that our level is already even higher than what I heard, because they don't have the experience that we have, especially during the war, like the experience that we've gotten over the war time. And especially when the war started, it became obvious that we need this method. We need this method in the country because it works fast. And the main aspect, of course, is working with PTSD. From our experience, if usually for PTSD, the first lines of therapy and antidepressants, that takes half a year. But if we use our model in our method that we've developed now, we need a month and a half of intense practice. We can get these military or these veterans to the level when they feel that they either go back to full life or go back to fighting. On our YouTube channel, our website, you can see this feedback of this military personnel, how they feel, how they felt in the process and after. Yes, it is a necessary approach. And we understood that about a year ago with Oleg Orlov, the head of our association. We came to the Center of Public Health and we discussed that, yes, it is necessary for the country. We discussed how we can move forward, because it happens that today that state medical institutions, special hospitals, it's kind of like officially allowed, but nobody wants to take risks. They work only with national protocols, and for some reason they are afraid to make a step to either side. And for that reason we discuss how we can take it to the state level. And if we talk about depression, they were more open. There are international protocols. Maybe without additional clinical trials, we can start promoting that. But if we talk about PTSD, so there are no international protocols, but at least 24 of different research already exist.
So they said, well, if we also had a study implemented in Ukraine, working with our veterans, showing that it is efficient, maybe then we could make it part of a national protocol. So we decided to make this study happen. I need to take my notes because now I will have to use some official terminology. So our study will be a randomized placebo controlled trial, blind trial, a study of ketamine-assisted therapy with the military with treatment-resistant PTSD. So it will be a clinical trial including one session of integration therapy plus 2 infusion of therapy, dosage 0.5 per kilo, and then there will be a therapy session, one per week. And there will be a control group which will be doing all the same thing. But with midazolam, this is just a sedative medication, which is a classic medication used in such studies for the control group. So our task will be to make a comparison of the outcomes, and if we get the results that we expect, we will present them to the Ministry of Health, and thus it will be possible to continue this work in Ukraine. Of course, it's not enough to just get a permission from the ministry. Also, we need to train specialists. And the program that is presented by Heal Trauma Ukraine, this program, which I am part of, is a very powerful tool, because group therapy allows to help more people, but also there are some difficult cases where we would need individual therapy, so group therapy would not be enough in such cases. So in our clinic, we are starting to work on this training program for psychotherapists, and we hope that when there will be permission to use ketamine-assisted therapy on a wide scale, we will be able to offer you a course which will be even more actually in terms of the content that our international colleagues can offer. Yeah, sorry, Vladislav, I have to interrupt you because we need to start our next session. Yeah, sure, just some more time. So we can offer you cooperation. You can refer your patients to us. You can also come with them. So we will be responsible for the medical component, and you will be doing the psychotherapy using any schemes that work. So we don't have to wait for a year or two. It is possible to do it now. So please get in touch with us. We can discuss possible cooperation. And if you have such patients, veterans or military with treatment resistance, PTSD, please refer these people to us. It will be free for them, because you know it is not so easy to find these veterans after they leave the army. Sometimes they just get lost and we cannot find them. Thank you for your attention. Thank you. And we are trying to wrap up till 2:30 so that we can have our Q&A session. So please, we would like to invite Zach, Nika, and Alice. Please come to us, Zach, Nika, and Alice. So they will be presenting a Heal Ukraine Trauma project on a group Ketamine-Assisted.
Hello again. So we're really excited to share with you all today about our group Ketamine-Assisted Psychotherapy training program, together with Zach and Nika, our lead facilitators. As I went over earlier, our mission is to help Ukrainians heal from the trauma of war so they can live fulfilling and productive lives. I do want to highlight too that we're registered as a 501c3, which is a nonprofit in the United States. And our goal is to have Heal Ukraine Trauma be our first project, and then take the learnings from Ukraine to other areas affected by war around the world. And so building it up to be a Ukrainian-held initiative, starting with Oksana and growing from there. So with our capacity building program, our goal isn't to provide the therapy ourselves, but to build capacity of Ukrainians practitioners to be able to deliver this therapy themselves. So we're working on that training together. And so why group therapy? The scale of the need in Ukraine is really high, and it cannot be met by a one-to-one patient-to-provider model. And it's also a really effective way to build community among veterans and other people as well. And as we've discussed in detail today, why ketamine, it enhances the effectiveness of psychotherapy, it's legal and affordable, and it has an excellent safety profile. So we have our co-facilitators, our lead facilitators here today are Zach and Nika, and we're super grateful that they've traveled from the United States to be here to do the training in person, not just online. So thank you both so much for traveling and being willing to be here for this. And we're working with Vladislav Mechanitsky, who you just heard from at the XBO clinic to deliver the experiential portion of the training, and Oksana Grashenko as well as a co-facilitator. So I'll hand it over to Zach and Nika to go into some of the details of the training program itself.
Thank you. So HUT has implemented a group CAP training program in 3 parts. We've got the online asynchronistic training, looking at different lectures and videos, as well as peer-reviewed articles, and moving into the second portion of the experiential, where folks are experiencing the group therapy protocol themselves, and then moving into the third process of supervision, how to apply that after they've been through it themselves.
So in total, Part 1 and Part 2 are 15 weeks, consisting of online and experiential training. Part 1, as Zach mentioned, encompasses lectures from global experts from all over the world, peer-reviewed scientific publications, weekly discussions, office hours, and a final exam. And this is a 7-week asynchronous online training course. Part 2 is an 8-week experiential course consisting of 3 group preparation sessions, 1 individual preparation session, 1 psycholytic dosing session to include a follow-up integration session, 1 group preparation session prior to the final psychedelic dosing session, 1 psychedelic dosing session, 3 group integration sessions, and 1 integration session. It's a mouthful. And here we have all of our experts from all over the world which are presenting in our training program.
So HUD has a variety of partners, and we're happy to be with XBO Clinic and UPRA, and Fluence is a psychedelic training program that's been helping out in the US online with folks.
So Part 1 is our online classes and material. So something we really like to talk about is that we are the only veteran-centered curriculum. Many other curriculums that work with veterans, they don't actually have a training program to define what trauma actually is like for people who go through combat or are veterans.
It's just one of the things that I think is really unique about the program is what are the contexts of what's being experienced by people collectively and subjectively. When you're thinking about our cultural influences and how that impacts trauma, a lot of training programs don't consider what's the influence here to start to pick apart, and they miss a lot of things. It slips through the cracks, whereas in HUT we're able to address that before we start sessions.
So for week 1, our focus is about trauma and how it influences through a collective and subjective experience. Week 2, we talk about how we best respond to psychiatric and medical emergencies if they come up, and how we can ensure client safety. Week 3, we talk about considerations for ethical psychedelic-assisted therapies. Week 4, we talk about influences of optimal psychedelic facilitation and what personal experiences have been valuable in training and which can be detrimental. Week 5, the focus is on core facilitation skills using psychedelic-assisted therapy and how many providers are approaching the framework of clinical and transpersonal experiences. Week 6, the focus is on group psychedelic experience. What frameworks have been beneficial for groups in clinical settings as compared to ceremonial settings? Week 7 focuses on the cultural influences support for military and veteran communities, from active duty to community reintegration, and how do shared stories and stigma play a role.
So here we have the experiential, the group, the individual, and psycholytic and psychedelic dosing sessions. That's just the overview of kind of what we're looking at that we talked about earlier. So the psycholytic dosing session. Why do we do psycholytic dosing sessions? For a lot of folks, they experience an increase of psychological flexibility. So any kind of unconscious material that comes up for folks, or any traumatic events, it makes it a little bit easier to access for folks and process it fluidly in a therapy session. There's an increased efficacy with this as well. So folks experience an accelerated treatment. They're able to be a little bit more vulnerable with their therapist. They're able to dive into topics a little bit more trustingly. And with that, you can take deeper dives that last a little bit longer therapeutically. So you have an enduring effect that's greater than just regular psychotherapy. The psychedelic, so kind of the macro dose, is one that you'll have with applications of inner-directed care. So there's an increase in enduring benefits that we actually look at when we have mystical experiences. So a mystical experience would be considered a transpersonal or beyond the personal, and connecting with something kind of greater than yourself. Increasing those benefits, we're looking at 2/3 of individuals, about 66% of people who are having mystical experiences reporting greater outcomes, up to 2 to 3 months. An increase of potential mystical experiences when you have macro doses, I think, is kind of the goal of all our psychedelic sessions at times. It's considered the most effective psychedelic-assisted therapy intervention, and can address multiple polytrauma aspects. So when we're talking about the actual baseline of trauma and the biological effect therein, and also the moral injury that can come into account as well. The enduring benefits, it's one of the aspects I think that are really important to include as well. It's greater than psycholytic as well as greater than therapeutic. So one of the justifications of running through an experiential is actually to have your own understanding of orientation in a psychedelic experience. When I was moving through postdoctoral experiences and more academic experiences with folks who had never actually had a psychedelic experience themselves as principal investigators or therapists, they were actually having a really difficult time understanding what their client or participant was moving through. This caused a lot of issues around trial outcomes as well as therapeutic outcomes. And so we started to coin the term of psychedelic peership in order to have a kind of peer support aspect. The assumption that someone with firsthand experiential knowledge from previous personal psychedelic use can benefit the facilitation of someone else's psychedelic experience. What we look at in the outcomes of that has been a decrease in stigma. If a patient or a participant is moving through a psychedelic treatment, the fact that their therapist or facilitator has had a similar experience actually makes them feel a little bit better about theirs. And the therapeutic alliance starts to go up a little bit, the trust factor there, and the confidence that they're going to be cared for in the experience well. Therapeutic efficacy follows that. When there's greater therapeutic alliance, you're looking at higher outcomes and enduring benefits. One of my favorite examples of it in the U.S. is MAPS's MT1 studies. They moved their therapists through their own MDMA trials to work on their own specific intentions in their lives, aspects of their lives where they needed to grow or heal, to move through that process as well. And one of their therapists came back with some of the wisdom that he feels that he now understands how to walk away with a clearer image of how to be present with and for the client during their session.
So for the third part is our supervision. After the online and experiential portions, therapists will conduct group therapy under supervision. So we will be meeting with our therapist every 2 weeks and providing them support, discussing difficult cases, and making sure that they're able to appropriately take our protocol through to show the efficacious results. And the following core skills are really going to be focused on. So the therapeutic alliance, we want to make sure that that bond between the participant and the provider is strong enough to support the person going through this experience so that they have the best possible outcomes, orientation and approach, and clinical outcomes.
So thanks so much for giving the summary of the program. So we, just even with this pilot program, which we're doing for 8 therapists, this is kind of a projection of how many veterans we could reach with these 8 therapists working together in pairs. And so assuming that they could do 12 groups annually and up to 96 veterans per team per year, that means that their reach could be around 384 veterans in their group sessions next year. And so in terms of our expansion strategy from here, this was a pilot. This is the first time we were doing it. And so our goal now is to assess the effectiveness of the pilot program. We've taken, our participants can probably attest to this, but we've asked for a lot of feedback and evaluation on the different aspects of the course to make sure that we're providing them with everything they need to feel confident as providers. So we're going to, from there, refine the program accordingly. This may look like adding in additional modules, changing the timeline, whatever the feedback is that allows the practitioners to get what they need out of the course, and then expand it to reach hopefully hundreds of therapists, and then who will be able to reach ultimately thousands of Ukrainians from there. And as we go forward as well, as Dmitry Gurin was talking about, with hopefully movement on the MDMA front, we're looking to incorporate additional medicines into the training program as they become available as well. So we're really interested in making sure there is geographic spread in the therapists that are coming through our program, so the Ukrainians throughout Ukraine can have accessibility. And so we really welcome, I know a lot of you in here today are providers yourself, and so if you're interested in coming through our program, would be delighted. And if you have any suggestions on how we can maximize our reach or what we can do better, we're all ears. So I look forward to hearing from you all during the Q&A session. I'll hand it back to Oksana so you can hear from our participants.
Дякую.
Thank you very much. Thank you, our speakers. I'm trying to intensify everything. I would like to ask the participant of our course to come here to the stage. Andrei, Igor, everyone, please. You know, they are like astronauts that we are sending first time into space, and then they have press conference. They need to report of everything they've seen. Thank you. So we have limited time, and we have a lot of you, but we want to listen to everyone. Please share very briefly who you are, how you work, and your impression about the program. Glory to Ukraine, glory to the heroes. I work in the Department of Psychiatry in Lviv Medical University, and I'm a veteran. I've always been interested in addictions and how to help people in the best way. And I had a chance to join Heal Ukraine Trauma course on ketamine-assisted therapy, and to be honest, so we tried to use it when it became allowed. We tried to use it with alcohol abuse disorder, but then it was prohibited. My feeling from the course, in like slang, I'm awed. So the amount of information I received, information from different angles about culture, about social aspect, pharmacology, medical, and I didn't know this before, even though that I've been working with psychiatry for like more than 20 years. So thank you, the organizers, thank you for this chance. And I hope that we will integrate CAT into our healthcare. Any comments, any complaints? Because like it will look like we just invited you to advertise. I present the course myself, so I know what it means to teach, so no, I will not criticize you. Good evening. Oh, good afternoon, actually. My name is Camila. First time in a ketamine session, I experienced a year ago, and it was with Vladislav in XPO clinic. I really like therapy. I really like the approach. I came to my head, Julia, and I said, we need to do ketamine-assisted therapy, and let's study more about it, and let's do it in our clinic. We read so much information, but something was missing. We wanted to find some peers. We wanted some people to discuss this topic, and by accident, I found UPRA, and then I got a letter about Heal Ukraine Trauma, and we got more about CAT. I was so grateful and happy that I could join this course. It's really powerful course. Honestly, it was harder than I expected. There was a lot of information, and I have to admit that I could not keep up with all the volumes of materials that we received every week. But the training helped us in our private center of ketamine clinic. It turned out it made our connection with the patient much better, but we faced some problems. As Vyacheslav started talking about this, that patient that they come, they have a little bit of stigma about ketamine, that this addictive substance, that it will lead to some addictive disorders. And I also hope that 1 or 2 sessions with ketamine, and then without any therapy, without integration sessions, they immediately can feel better. Unfortunately, it doesn't happen. And so the first problem that we faced, that we definitely need to have integration session. We need to work with psychotherapist and CBT. So that is a must. And what to add? So you are a psychiatrist? Yes, I am psychiatrist. Because you look quite young, so to say that we didn't select students. Yeah, we had a lot of applications. Very difficult to select this group, but we try to choose those who are going to start working immediately with patients who can practice. And for us, it was the priority. And one more thing. Yes. Thank you. Any complaints or any criticism? Yeah, you said that it was too much material to read. Just to read as a formality, it's okay. But I wanted to actually study it and to learn the essence of transpersonal psychology when I tried to learn more and to get to the core of it. And when I found out that there was a huge organization, transpersonal psychology, there was a lot of material, and so we studied for 2 months. Yeah, overall it will be 3, but yeah, we've covered 2. I think it should be at least half a year. And of course, supervision, definitely it's a must. Practical part, and then supervision is very important element. Thank you all. Hello everyone, Olesya Bondarenko. I'm clinical psychologist here in Lisova, Polyana. I work with our veterans and military, and I'm very happy to be a part of this program because now Ukraine doesn't have trainings for PAT. This is basically the first course, and it's really very informative, really filled with all kinds of information, a lot of articles, and it's evidence-based and based on science, which is important to me. And why I joined this program? Because as Ksenia mentioned, that we are doing ketamine-assisted therapy here in Lisova, Polyana, and I'm sure that the experience that I received is going to be extremely useful. I want to thank our trainers who are constantly in touch with us. They support us all the time, and they answer all our questions. And all our discussions, when we have group discussion with our trainers, it adds to this experience and a better, deeper understanding of this program. So thank you very much. And criticism, only one, that maybe to have it not so intense, so to go slower, because it's really very intense and a lot of material. Sometimes I could not keep up with everything, and sometimes I just put off some of the materials. I like that we had homework, so for you not to think that it's just like we just read and that's it. We have very interesting homework, practical cases that we need to reflect on, provide answers, and then you can get feedback from trainers about the understanding what is right and how you can improve it. So that's really great experience. Thank you. No criticism, just to make it slower. Yes, I understand that criticism just about time. Yeah, these people, they already have extremely crazy workload, and they cannot just leave everything and to have a course. Yeah, but we cannot wait for regular studies, like for students only without working. Yeah, but they do their best. My name is Vyacheslav. I also work in Lisova, Polyana. I've been working here since 1999. I psychiatrist. Then I also studied there using with addictions. Then psychopathology. Then I again studied psychiatry. So since 1999, I've been working all around this kinds of topic, and I believe that I'm an expert with working with addictions because I worked in a clinic and then in intensive care unit with acute states with alcohol-caused epilepsy and different acute states, and I worked with psychotic patients, and they had the psychosis because of psychedelics. So I learned about this topic from this angle first, and then in this group I play a role of more like a break. So when I get excited, I'm trying to pause, think. Because you saw what happens when it's not used properly. But I am supporting psychedelic-assisted therapy. I just need to think twice or three times before doing something and analyze situation from different angles. I really like the course. The information is very diverse and multi-layered. So when I learn this information, you can find second and third and fourth layer, and you have a lot to think about.
And you have some things you want to go back to and analyze. What I really liked is actually communication with Zach and Nika, because this is what gives me the feeling that it is a living course. It is well structured, but also it is like a living thing. So that's what I really like. As for the criticism, yeah, it could be a bit slower, less intensive, so that we would have more time to work on the materials, but for me it was fine actually. Good afternoon. Andriy Imperial. I'm almost the same as Vyacheslav. I can tell all those things about myself, but I did not work as a sex pathologist, and I also used to work with people with addictions. And since then, since the 90s, I was looking at the transpersonal psychology, because in 1990, 1991, there were some translated books by Groff and other authors. So I was curious about that. And there was a period of time where we work it in more practical ways with psychedelic-assisted therapy. So we came closer, and then we stepped back. And lately, I was talking to our director, and so we agreed that we would like to start working with ketamine in our facility, but so far we are not doing that. But this course gives us a lot, because now there is a lot of information about psychedelic assisted therapy, but this course gives us this information and gives us information which is evidence-based, which is good quality, and which is systematized. And it is possible to work with practitioners who have this experience, and we can not only learn some materials or some facts, but also we can have discussions in this very friendly and supportive atmosphere, and thank you for that. Yeah, so we have told a lot of things, and you were asking for some criticism, but it's the same for me. Sometimes I did not have enough time to study all the materials, but I promise that I will complete all those things that I have not completed. And I want to thank to all the participants of our group, because you are all great people, not just good professionals, but also nice people, and it is great to spend some time with you. So we used to only meet online, but I hope that also we will meet face to face. Thank you. Daria Dminska. I'm a candidate of medical science, clinical psychologist at the XPO Center. So I have been working for a year and a half in ketamine-assisted therapy, and also I work with hypnotherapy. So I think that this is closer to the Jungian tradition, in which I had quite a big experience. And when you learn how to pronounce one word with in different ways, till your teacher tells you that yes, I believe you, now it's fine. So Vladislav Matrynitsky, he also is one of my teachers, and he was part of my experience of treating depressive episode. So I'm thankful to our trainers who prepared all the materials for us and who have created this wonderful atmosphere. And we now realize how this atmosphere is important, and how important it is to work with your partner when we work with our clients also. And for me, being part of this program is very important also when we talk about how to guide the clients, whether this psychotherapy sessions and integration sessions. So this is about being a guide, and this is what is new for me. And that's when you help us to have a good supervision and to make psychotherapy not just directive. That's how it is usually done by psychology practitioners, but use other approaches also. And thank you for creating this team, which is really wonderful. And I understand that when we bring medicine and psychology together, this is also a model of how psychedelic assisted therapy should work in Ukraine. And this is a guarantee that we will have safe safety, and that we will have cure and we will have the outcome we want to achieve. So thank you, and I hope that the practical part that we are going to do will make the outcomes that I see now for us even stronger, and it will help to work with our clients even better. And about some criticism, I would probably like to mention discussing some clinical cases, because usually every day we have from 1 to 4 ketamine-assisted therapy sessions, and it would be great to talk more about that, to discuss the patient's case, the disorder that the patient had, and how we started talking about patient's soul. Okay, so I hear that you have a request for supervision, right? Yeah, kind of. Good afternoon. I am a psychologist and trauma therapist, and I'm also a veteran. I was in the army in 2014-2016. It was quite difficult for me to come back after the concussion and after the wound. And by the way, I was a patient of this facility. Later, I was able to go back to work, and this is how ketamine-assisted therapy works. And I would like to talk about the symbolism, because Vladislav and other colleagues were mentioned the Union approach in ketamine-assisted therapy. And I was looking at our group, and I'm a combat medic, and usually combat medic is the second last to in the group. So I see that we have this symbol in our group as well, and it means we are moving in the right direction. I think I'm happy to be part of this pilot project. And I think that this project is very important, and this therapy is an important model that will allow to scale up support programs for veterans, because this program is focused. It is focused on veterans, on group therapy, and veterans, for them, usually it is easier for them to have group therapy, because they feel safer in a group rather than in an individual session, and it gives better results often than one-on-one therapy. Because that veterans are not always happy to start this one-on-one therapy sessions, because they do not think that psychologists they can be their peers and they can support them. But if we are talking about group therapy, it allows to cover more people, first of all, and also it allows to make this work more efficient. This training program is very interesting. I like the holistic component. I like that we are talking about various aspects that are beyond the traditional science, but they are of great value. And that is an important thing, that we are not just focusing on some protocols and some approved approaches, but we try to be as efficient as possible. And I would like to thank the colleagues because being part of this group allowed us to share our experience. So it is important to see all these positive and negative aspects. And the wider is the picture that we see, the more efficient our work is. And I would like to thank the organizers, Zach, Nika. I'm so grateful to you for making it happen, for preparing for this course, and for everything that you do for Ukraine. Hello, my name is Roman. And in our group, I often talk after Igor, and we do the same thing today. I want to say that I used to do field shooting, and this is where you need to be well coordinated. So we are coordinated. So I worked here in this facility as a psychotherapist in the rehabilitation department. And I would like to agree with what Igor said, that veterans, they are reluctant to work with the psychotherapists. So they thought that we would write something in their medical records that they would not be able to go back to the battlefield. And it was hard for me to understand this process initially. But then I observed that we were able to build these relations with them, and the veterans even gave me a call name priest, because I have this bird, and they kind of came to me as they come to the church. And now I work as a psychiatrist at the Central Polyclinic. I work with young people because I work with students. And I also work as a consultant on addiction, and I work with the drug store harm reduction project. So that is one of the projects that Alliance implements. And it is interesting actually that I went to this one festival where there was supposed to be a lecture from one of the veterans who did psychedelic-assisted therapy. And when I was there, I had these inner feelings and I had this curiosity. So I approached him, I asked where I can learn more about it. And so I did a number of courses from MAPS, also a course on integration of psychedelic experience. Also, there was a course from Chernivtsi University on trauma-oriented or trauma-focused psychedelic therapy. So actually, this is one of the Ukrainian universities, and they also did this course. And at some point in the drugstore project, they said that I could take one more course as part of my training, and I chose a course on ketamine. Because I remember that there were just several hours before the deadline when I decided to apply. I did not have high expectations, but actually I became part of the project. And now I think that it was not accidental. And I can say that the knowledge that we have received here, we can use them not only for ketamine, but for other mind-altering substances as well. Because these materials, they relate to different substances and different approaches. Because, for instance, I'm a Gestalt therapist, but I like process-oriented therapy. I really think that it is efficient, and some things that we learn I already use in my work, such as psychoeducation, such as explaining what is happening to the patient. And I already had 2 psychedelic sessions during this year. One of them was kind of scary for me, and I did integration for quite a long time. The second one was easier for me to understand.
So today I understood that if I had this material before, it would have been so much easier for me to go through integration and healing, and actually to meet the request that I had when I entered this psychedelic-assisted therapy. I'm really grateful to Nika and Zach because we really have this connection that I actually forgot to turn on interpretation, and we were doing the mindfulness exercise, and I still got into the forest and I still followed all the instructions. And I complained then that I had some pain, but it's like this group work, it turned into this dynamic process in my life that some days I just needed to resolve some issues because like many issues came up while we were working as a group. The course really is very intense. Every lecture or video material, some videos I watched a few times because they answered many of the questions that I had during other courses, like what to do in this or that situation. Or they explained some of the issues that I never integrated in my psychedelic experience about this transpersonal work. This lecture was like, it really put everything into the right shelves and boxes. And all this course, I had a high level of anxiety because I constantly needed to keep up. We had like blackouts, and I tried to keep up with the materials. Today, I finished doing my homework at 3 a.m. and I have only one technical issue, as I read a lot of material while I was on traveling in public transport. So sometimes if we use it on mobile device, so then like the text does not work properly on mobile on mobile phone. Probably it's just some problem with the website or something. So sometimes I ask Oksana to resend it in a different format. But time was very tight, but we managed to do everything we wanted. Thank you, everyone. And I understand about technical issues that we will need to find some additional partners in Ukraine because we are not good with technical devices, and we need to find some digital specialists that they will simplify the technical approaches according to the standards that Ukrainian therapists like demand. And I don't want to let you go. I have one more question to all of you. The question about the next panel. So we are talking about the future of CAT in Ukraine. And we rely on you a lot in that, and we saw like all these numbers, how many people you can work with, and you are the very first ones who finish this course, who will finish this course. We are hoping to be part of your supervision. So I understand that we can talk forever about this, but briefly, how do you see the future of ketamine-assisted therapy or psychedelic-assisted therapy? Let's talk about the next 5 years, because in Ukraine it's very difficult to plan like for 10 years. Yeah, okay, let's go in the opposite direction. So I wanted to add that because now I have an understanding that modern psychiatrists should have not only medical knowledge and skills, but they need to understand spirituality, personal, and maybe to be a little bit of shaman or priest, to understand the processes which are happening. And as usually, like the list of psychiatric medication, like we haven't changed since 1960s. So okay, I know okay, I need a very short answer. I'm sorry. Like I know we discussed all the issues. I want this to develop further, and the trainings that we are going through, like so that I hope we can use soon not only ketamine but other substances. I'm sure that my colleagues will give a wider vision, but I want to emphasize one very narrow aspect for a military psychologist, and this I'm convinced that ketamine can be and must be used actively when we are preparing the military, especially special units, and actually wider range of military, so that we can decrease the impact of combat stress and also on decompression stage. I don't want to go into details, but I truly believe that it can be effective for these two aspects of working with the military. I actually continue what Igor has started because as he was talking, I immediately started to think about veterans and the military, and combat medics, and they ask, like, can you do it for prevention? Can you do prevention for burnout? So not to wait until you burnt out and you have some disorders and comorbidity, but actually to do it differently. And we even discussed that it is very raw material. It's only some first drafts of how we can build a system so that the military can come not only once a year when actually somebody else bring them at that stage, but maybe after a month and a half of their service, like to come and so that we can adjust to the psychological aspects of the person who is serving. Not everyone can serve without any psychological assistance for like half a year, even strong people, and we know that they have extremely high level of responsibility and they need this assistance. So those people who are the strongest, they might need this assistance the most. And another aspect that I would like to highlight is probably we need to look at the group of potential supervisors that I believe that this is the safeguard of this recreational ketamine, which is already on the market, and not only recreational ketamine. So it is important for us to be here, and a lot of information that we heard today, many people in the room, you know this information, but we need to show that it is evidence-based. This is on the level of science. We have protocols, we follow like protocols, clinical trial science, and we need to focus on security and safety. And I think that we need to develop this capacity and actually to be ketamine-assisted therapy and actually to use it in therapy properly. I would like to add a bit that I would like to see CAT and PAT as a tool which works and which is widely used. So that we don't waste time explaining how to overcome some stigma, like how to organize it, how to prove, but actually to use our effort to truly use it in therapy, and to use it as one of the available tools which works well. And I am for good quality of this therapy. Not much to say. I want to see ketamine-assisted therapy and psychedelic-assisted therapy. I want to see it on professional level, because there is a fine line between creativity and incompetence. Of the person who doesn't have competence in this issue. It's very easy to like not to do it right, and I want people who are in this therapy, they need to be professional, who had gone through necessary education, and who would have some good conscience when they're doing this. I absolutely agree with Vyacheslav. And we in Ukraine rely on international experience and so on, but we see that it's time to build up our own experience, taking the reality that we are in now. And therefore, I would like to say about psychedelic-assisted therapy, regardless of which substance we are talking about. I want to see how it is used for PTSD, because that's what we are going to face. We are already facing this, and we can say that therapy works, but there are some states that psychotherapy is not enough, and PAT can be a helpful tool. But it has to be medical. It has to be not recreational usage of magical pill or like with not exaggerated expectations. It has to be with specialists who had gone through necessary education, have experience, and who have worked with supervision. And that's the future that I see for PAT in Ukraine. Thank you. have some concerns about like personal experience of past experience of therapists, whether they need to go through this therapy, psycholytic or any type. Yes, I believe it is correct. During one of the group sessions, I think you, Roman, you mentioned really correct comparison with Quest Room, when there is a guide who says like, oh, you have a Quest Room and you will experience this or that, and that's pretty much it. If you don't die, then that's a good experience. But it's completely different when the guide says that be careful there because you can trip over like a loose carpet. So it is very important that when we talk about clinical trials, yes, of course, we will have clinical trials. Even in our group, we have representatives of state and private sectors, and both sides will be working on some trials. Maybe the samples can be different and comorbidity can be different, but we will work on clinical trials. But I believe that it is important to clearly define how therapists can go through the training, how therapists will go through their personal experience. That is important to have clear procedure for that. About 8 years ago, when I was teaching doctors, when I was giving them lecture on cannabis, I told them that it will be decriminalized and then legalized in Ukraine, but we would need about 7 years. Well, it was 8. How did I know that then? I think that I just could make a guess based on the literature that I was reading, that Ukraine wants to leave the status of third world country and to join the Western world. And Western world use different approaches than what we use. So a lot of notions are stigmatized here, including ketamine, which is stigmatized, or psilocybin, but here in Ukraine they are used. So we just like these substances are growing well on our soils. We just don't know everything, and we have a limited access to these tools, and this limitation comes from our government. We actually have good access to alcohol and nicotine, but when we would talk about difficult cases in psychiatry and the states that I face in psychiatry over the past 20 years, we are ready to try anything that will help our client. And I know, and using the tense, that tense point of Caritas, yeah, I believe that miracles happen. I give the space to miracle, and it will happen because Ukraine is moving towards the Western world, not the Eastern world. Thank you. Wonderful. Thank you for this positive note.
I would like to offer a Q&A session, but I will not offer it to you because we have David Nutt with us in Zoom, and we will have a Q&A session, and I would suggest to also talk to the practitioners and to specialists in ketamine-assisted therapy. So these people, participants of our program, they are very important because hopefully after the course ends, they will be working, they will be doing supervisions. So thank you to all our panelists. So, Vyacheslav, please. stay with us, because now we will have questions and answers with those people who were our speakers. Zach, Nika, please come here. So all people who were presenting today, Vladislav, also please come join us. Ksenia, if she has a free minute, and David is with us. Thank you for joining us. So, questions. We have a first question. If you know whom you are asking your question to, please tell. Well, I would like to thank for the symposium, bringing together theory and practice. I have a question about two identities. As a psychotherapist working with cases for treatment-resistant depression and PTSD, and also I have an identity as a client, because I also went through therapy. I had resistant depression and PTSD symptoms. So I can understand more or less how it happens in Ukraine and how this experience is for the clients. Today, several people mentioned that there is this practice when ketamine is used to work with addictions. I do not have this experience, but I think that the question of addictions is now very relevant, like for civilians and for the military, also alcohol addiction. It is very important. So I would like to learn more about these nuances and differences when we treat patients with addictions. Do they need to be hospitalized, admitted to hospital, or would there be a different number of sessions for patients with addictions? And considering that this is kind of a new topic, there will be some patients with high vulnerability. So when doctors or therapists work with such patients, there is some power disbalance. So what are the mechanisms in Ukraine to ensure safety of the patient so that clients, when they come, they can feel safe?
David, could you take the first part about, I think, with the addictions, use of psychedelic
Він,
assisted
він, чує,
therapy?
він чує переклад.
Це
Сам.
перше питання.
Are you asking me?
Yeah, if you could answer this first question.
Me? Okay, yes, sure. I think the principles are very similar. I mean, although they're not fully established, as we don't really have any definitive comparative studies of different forms of therapy for with ketamine for anything. But the underpinning physiology is the same. It's about disrupting patterns of thinking and behavior relating to alcohol or other drugs in the same way as you disrupt patterns of thinking about trauma or depression. Our experience has been to use 3 ketamine sessions about a week apart. For addictions, we're now developing a study where we're probably going to do 4 weekly sessions. But beyond that, I don't think there's any major issue. I mean, obviously, the training subsequently, the integration for addiction needs to focus on the reasons for using the drug in the first place and ways to help people resist relapse later on if they've managed to cut down or stop. So there are underpinning principles relating to addiction that's very important. But the actual therapy during the ketamine and after the ketamine session itself, the insights, I think don't need any particularly special. You don't need to be an addiction expert to use ketamine in this circumstance. What you do need to do is be a good therapist.
Дякую дуже. І ви хотіли додати?
Thank you, and you wanted to add, right? Well, that is quite a big question, and it is difficult to give a quick answer. because the question of addictions and using ketamine or other psychedelics, it is the question of what kind of addiction we are talking about. So if the person uses stimulants or if there is a polydependence, then probably I will not be using ketamine. If there is a...
Let me just say a few things about that. We've used ketamine to treat ketamine dependence. And the whole point, and this is quite critical, is the intention. I mean, I heard the last hour of your discussion, and there was a lot of comments on avoiding recreational use, which we fully support. But people coming into therapy are not using ketamine recreationally, they're coming in to use it to change. And I therefore do not think it's a big issue. I think it's a theoretical issue, but it's not a big issue. If people want to change their attitude to their addiction, ketamine is the best treatment you have at present to facilitate that change. Using it 3 or 4 times is unlikely to induce a dependency, particularly as they're acquiring skills to avoid dependency. So I actually have very little concern about it being used for any addiction. And already there's a study going on in the US using ketamine for methamphetamine addiction. So I think the concept that there is an addictive drug is a slightly incorrect concept. There are people who use drugs recreationally and get addicted to them. There are drugs that people become addicted to, like alcohol, when they use them to treat disorders like trauma disorders. But you have to look at the reason people are using it. People are using ketamine in a therapy to overcome what actually, in many cases, is the trauma of addiction. I don't have any problem at all. I think it's very unlikely that people will get addicted to ketamine, particularly if they can go out and just buy alcohol if they do relapse. So I don't think we need to create for ourselves greater hurdles, greater barriers to help people.
Yeah, I want to say that I think that it is a case-by-case approach. Saying that if we have addiction and then we take a protocol of ketamine-assisted therapy, that's a question. We should look at the patient. And if we look at the protocols for using ketamine for addictions, here we have a classic protocol for psychedelic assisted therapy when there are dosing sessions and then integration sessions. And also there is this doctor who worked in Leningrad in the 80s. Yes, right. And he worked with around 1,000 of patients. And I think that he used not criteria of PAT, but he used this approach for emotional and stress-based therapy. So that's my comment, basically.
Yes, I think let's give him credit. And most Western use of ketamine in therapy has been driven by Evgeny's research.
Дуже дякуємо. Ми просто будемо зараз...
David, thank you so much. We would like to take one more question because we are running out of time. Sorry. Good afternoon. I'm Katerina Shevchuk. I'm a clinical psychologist. And as I understand, this therapy gives a good neuroplasticity for the brain. And I think it influences the memory for processing some trauma. But question about this person not going back to it afterwards, so that is about cognition also. How can we make an impact here? And I want to say that each therapy approach has some opportunities. And here we need to explain to the person that we can work on some trauma, but also we need to explain about thinking and cognition. So not for the person not to go back to these things. So can this kind of therapy help with that? So I would like to ask David to give a response here about this neuro aspects.
Okay, lots of people. Всі хочуть відповісти.
I mean,
Девід,
obviously
будь
there are
ласка,
multiple-
коротко ви
Yeah, so David, could you give the response first, and then we have some experts in the room who will add to what you say. David, over to you.
Oh, thanks. I think there are several different phases that ketamine produces in the brain, which are all therapeutically useful. There's a disruption phase, when people, possibly for the first time in months or years, escape from, say, the craving for a drug or the repeated thoughts of their trauma. And then there's a process of reframing it in the context of other things in their lives and seeing that they can think about it differently. And then there's a neuroplasticity which can be utilized for the therapy to create new schemas, new cognitive schemas. And I'll just finish by saying, I mean, it's fascinating talking to patients who've been through this, who say they reframe their whole relationship with alcohol. That the alcohol doesn't figure in them. I don't feel they need for alcohol. That was a previous kind of life. The drinking life was and now they're a different person. And so they kind of reset their brains so that it's not being driven by drugs or alcohol again. So it's multiple processes, and each of them contributes.
Okay. Дякую дуже. Олег, ви також?
Thank you. Oleg, you wanted to comment? Yeah, I wanted to say that I work since 2012 in science, and also I do psychotherapy practice. And I want to say that psychedelic-assisted therapy is not a separate psychotherapy method. This is just when we use certain substances to create favorable environment for change. And what method can be added, that is a question. There can be a range of methods. It can be psychoanalysis, it can be CBT, and a change is not just about giving a drug to the patient. It is to facilitate the process of healing. And psychotherapy is what gives the effect, actually. And the most work happens during the psychotherapy sessions. For instance, one of the good projects about to be implemented in Ukraine was mentioned, ketamine plus EMDR. Or also instead of EMDR, CBT can be used, but actually ketamine is what facilitates the process, not is the essence of the process. Sorry, I would like to also share my comment. So to answer your question, I would like to talk about two aspects. First one is pharmacology, leading to increased neuroplasticity. And the second aspect is psychotherapy. And here we have again two models. One is when there is a ketamine session, and then there is integration psychotherapy, where CBT or other method can be used. But the main essence about using ketamine is to have this altered change of consciousness when we have this opportunity for deep psychotherapy work. And that is not about cognition, not about thinking. It is actually about switching from this critical thinking and going deeper in the subconsciousness. This is what gives the biggest effect.
And after that, in integration session, we can, of course, go back to critical thinking, to CBT, and so on. But in this process, we need to be more shamans. We need to create the space for a patient and to walk with them. And this is not as therapy itself, it's art, how you work with your patient. It's a bit different. Thank you. Good afternoon. My name is Ruslan. I'm a psychiatrist and I work with addictions. And for the past 3 years, I've been doing research on using ketamine working with disorders and substance abuse. And I would like to draw your attention to a different side of using ketamine-assisted therapy. There are complications, and they can be the vomiting, dizziness when you leave the trip, and with some slight cognitive. So you still need to remember that it is anesthetic and is hypoxia, and it is so some cognitive changes. And I would like to ask those who already practice. So what do you do with these complications, and which medicine do you use, and like with this to fight with the side effects? And of course we have these side effects or like these consequences after getting out of the trip. Vlad?
It's difficult to show up and actually speak in criticisms to anything that's being supported, so thank you for your bravery. There are many different things that we can imply. There's specifically for my specialty in psychotherapy, there are different aspects that you can concentrate on if somebody's having an adverse effect to kind of create a more deeper connection with what's coming up for them, not so much running away from it, but allowing them into their experience, whether that's biological or psychiatric or a spiritual emergence that's coming up. And when it comes to the medical side of it, I'd like to highlight any wisdoms that my co-facilitator has had here. But it looked like you would have something to say as well.
I can say that the main difference is that we have low dosage in comparison to anesthetic use. So it's like 10 times smaller dosage than you use. And all these adverse effects, over the past 6 years, we experienced very few cases. And so we didn't have all of these consequences that you mentioned, because we use the dosage 0.5 1 milligram per kilo, and these are not the doses that can provoke these adverse effects. And if you talk about vomiting, that's people with vestibular feeling, and basically you can ask whether they have seasickness, and if people are prone to that, then we give like the medicine for that, and then you don't have any adverse effects. So your concerns are a bit too high as like in comparison to how often it actually happens. No cognitive consequences if you do proper screening. If you don't select people with dementia or already people who have some problems with over the past 6 years, we had one case. There was a 70-year-old woman. Physically, she was very healthy, but after the first or second session, her cognitive functions a bit decreased. And based on the literature we had available, we knew that it was temporary. And it is true, a week later, she went back to normal. We stopped the treatment, and no long-term consequences at all. We need microphone. We cannot hear. We need microphone. So this is a natural process that the person needs to go through, and after the trip, the person still in this state of increased neuroplasticity up to 2 days, and internal processes are still going on. So these processes, so we don't need any intervention if we don't have any urgent adverse effects that we need to intervene. Nika, yes, Nika, and then Oleg will comment.
Right, everything can come with risks. There are cases in which these adverse effects can happen, and we do need to be prepared for them. That's why we do medical screenings to ensure that we can have the best supports possible. Like Vladislav said, we provide Zolfran for those who have nausea. And some people, I just want to clarify something. Are you talking about HPPD, the studies around that? Hallucinatory, assistant psychedelic. Yeah, BPD. Is that what you're mentioning? Referring to?
Ви говорите зараз про які дослідження? Бо говорили, що ви проводите дослідження.
Yeah. Because there is a lot of misinformation when it comes around
тому що є дуже
HPPD, so I just wanted to address that as well.
Навколо цього питання, так.
Дивіться, я ще коротко до того додам.
I just want to add that we will have one separate issue that high blood pressure is one of the counter indicators, and if people had some brain trauma, then sometimes blood pressure is an issue. It can be an issue, and this has been studied, but maybe not researched enough. And to be very specific, if you are practicing that, one of the tasks for us is not just to talk about positive effects, but we also collect issues. If you want, maybe we can cooperate with you, and we can collect cases where you experience this. So please come, let's cooperate, and let's collect all the information, like not just praise this method. Good afternoon, my name is Andriy, and maybe Zach, most probably, can describe the situation itself, how group therapy is organized with ketamine, because it's more obvious how it's done individually. You have therapists and psychiatrists, there is a client who is in a comfortable seat, but here we have a group of people. What unites them besides that they are all lying in the room, and that's they are in a safe setting. So what is the group dynamic of the therapy? That's first question. And second question is, it is known that the biggest therapeutic effect from with PAT, this would like that so-called heroic dosage. And do you use the same concept when we work with ketamine, or the rules are different and different paradigm? Because I understand that we can have some so for you to actually be able to talk to a client during the session, then it cannot be heroic dose, so it has to be like some specific dosage. And or maybe you can use two different approaches, heroic dosage and then minimal dosage when you actually can talk to a person. Or maybe you have, is there a favorite or leader in which approach is used? Thank you. And before Zach answers, I would like to warn you that we need to finish soon, so we will allow only one more question, and that would be it.
So a lot of the time I'm resting on former practitioner named Irvin Yalom, who is well known in the States for group psychotherapy, that really puts the onus on group intelligence. So the fact that the facilitators are a part of the group, but they are also relying and collaborating with the group itself to start to run and maintain its own health. So we may have some sort of a leadership role, but we're trying to step back as much as possible and allow the group to step in to their experience and collaborate with each other. And so there are formal steps that the group will actually take to develop their own intelligence in that sense. 3 of them break down into dependency, the first one. being a dependency on the facilitators to step in, psychoeducate occasionally, or kind of guide people through what is good group health. And then a kind of rebellion at the second stage, kind of like with your parents. You don't know me. Well, get out of here. I know how to take care of myself. And so allowing yourself to kind of step back and be less of a facilitator and more of a quiet presence in the group health. Allowing that also to kind of be a protection in case that energy moves into another participant's place and creates kind of a scapegoat where this other participant might be ousted from the group. So really maintaining it with a quiet presence, but making sure that if you need to step in and become a scapegoat yourself, that rebellion can continue on with you as a facility. You do so correctly and keep everyone engaged. The third stage being the cohesion, that group intelligence has formed, that people are in states of altruism where they're there to share and heal together. And you're starting to do a step-by-step cathartic experience with people. So they're then playing out familial experiences from childhood in their relationships, similar to the rebellion with the parents. We're interacting with those formal relationships in more of an external way. And again, stepping back, allowing the leaders who you actually saw as participants here who were speaking on the stage. There are leaders within that group already that are leaders of love, that are thought leaders, that are actually a part of their own group intelligence and are facilitating in their own way. So I'm really monitoring that with my co-facilitator, Nika. And when it comes to the dosing sessions, there's a variety of ways in which to address it, because it's a case-by-case basis with everybody's physiology and whatever their experience is with psychedelics. As big of a fan as I am of macrodose experiences, there's something to be said respecting your own protectors and your own internal experience to take deeper dives within yourself, because the medicine is just the catalyst. What's actually being activated is your mind, body, and spirit. And learning how to work with that is the ultimate goal. And so as I'm thinking about macro doses for specific people who need them to be able to break through and break down some protectors, I'm also thinking about how to walk it back so that they're able to really go through an interpersonal experience themselves that really helps them in their experience, have a therapeutic experience without using 5 or 6 grams of whatever it is we're using.
In our practice, in our clinic, so with latest protocols, we are not as limited with minimal dosage, because we can use a wide spectrum of dosage, and we can start with micro, and then based on the experience of the client, and we can increase the dosage because we need to see what dosage is necessary for this particular client for them to achieve the effect that we want. So we can increase it if necessary. But of course, with all the safeguards, of course, it depends on the physical and mental health of the patient. And we need to have individual approach for dosage which would work for this particular client. It can be last question now.
I see that there is a question over there.
My question is to David, I guess. I was wondering about people who had experience of ketamine use prior to entering ketamine-assisted therapy, let's say recreationally. Should they be automatically excluded for such programs, or can this still be effective for them? Thank you.
As I said earlier, we've treated ketamine addiction with ketamine because it's a different intention, a different process, and with some success. So I don't think they should be excluded. I mean, obviously, if they are dependent on ketamine, then your approach would be rather different than if they merely had a couple of exposures sometime previously. But I don't think they should be excluded. No.
Окей, дуже дякую. Oh, you want to? Also, sorry.
Just wanted to add a little bit here. In one of the presentation slides that we had presented on earlier with the substance use disorder, a lot of times we see, especially with addiction, when it comes to the potential risk of ketamine addiction, what we're seeing is it's actually decreased when we use it in the way that it is intended to be used within our protocols. So those psychomimetic effects that pose that risk, when the client is using it in the psychedelic therapy space, we're not seeing those risks as high as we would when it's a recreational dose. So it's all about the intention, it's all about the support, and it's the way that we use the medicine within that structure.
Залишилося всього півгодини для того, щоб
Wow, we have just 30 minutes for networking because we think that networking is an important part of this conference. So